Thank you. Should we sit or stand?
Well, sure, let's sit down.
All right, thank you.
So I have to start this way, only because Governor Leavitt was supposed to be here for dinner last night, wasn't able to, because his plane was on the tarmac in New York for being de-iced and so on. So missed that. But this is such a rare thing, I just have to mention. So you mentioned that yesterday you spent time with Henry Kissinger.
So I'm on a board that Dr. Kissinger belongs to. 98 years old. He shows up at every meeting. And it was such an intriguing time. Of course, we couldn't help but ask him his take on the world with Ukraine. I had known because of other conversations with him that over the course of many years now, he and Vladimir Putin have had fairly regular conversations, simply because they had known one another, and I think Putin respects Kissinger's view of the world, etc. So I was curious about his take on this, and he said that, first of all, he acknowledged that Putin has lost a lot of stature in the world as a result of this action. He believes that the action will prove over time to have been quite detrimental to both him and to Russia. The second thing he said was that ultimately he believes that America, its allies, and Ukraine have to be careful in not pressing too hard on sanctions in a way that will stampede Putin into doing something truly stupid, and believes he's capable of that. And third, his point was that he believes we're getting closer to the point where countries like China may begin to intervene and do their best to begin to create some kind of a framework where there's a sustainable security. And he made an interesting point, and it is that for people around the world, for example, the United States, I'm old enough now to remember the missile crisis with Cuba, where Russia was actually putting missiles in Cuba, and it was a very tense time for those who remember that. And he said, there's to a degree that's what's holding the Russian people, is a sense of their security. Now, they're using all kinds of other excuses, but he said underneath that we have to acknowledge that that's going to be part of it, and that the solution ultimately is going to be to create some kind of buffer between the Ukraine and Russia, to where they're able to feel as though they have some security, but also a way out. Anyway, it was an interesting conversation.
But the reason that I want to mention that is that the world has gone through a number of crises or difficulties over the last couple of years. In particular, the pandemic is worldwide. It's not just in this country. But the pandemic has really put to a test the healthcare systems around the world, and in particular this one, our U.S. healthcare system. It's exposed some of the weaknesses, certainly also brought out some of the strengths of the system. Maybe you can comment a little bit about what we've all been through here and where we're going.
I think maybe the first lesson for all of us is a reminder that pandemics happen. They have happened for as long as humankind has been on the earth, and they will continue to. And we tend to forget as a culture. When I was Secretary of Health, one of the things that I took a fair amount of gave a lot of my energy to was the acknowledgement that we were going to have a pandemic at some point in time, and that we weren't well prepared. And one of the things I learned in that process was that no matter what you say about a pandemic in advance of it happening, it will sound alarmist because people they just have not been able to fully internalize it. Anything that you've done to prepare turns out to be inadequate after the fact. And I think that's a lesson that we all ought to continue to learn. I don't personally believe that we're out of the woods on this pandemic. Hopefully, because we've had vaccines and other things that have given us lots of tools, I think we're through the worst of it. But I'm of the view that we'll continue over a number of years now to have a lot of episodic experiences as new variants come up and so forth. But it has clearly revealed strengths and weaknesses of the system. For example, I'm of the view that value-based care, for example, was tested in this process. And I think passed the test. Those organizations who were receiving patients on a capitated or at-risk basis and had a steady stream of income have done better than those that did not, because their fee-for-service was interrupted on a number of occasions, and it has demonstrated the weakness there. I think it's also demonstrated the fact that we have obviously disparities in the care of people and in areas, and that's been demonstrated. But I also think we have learned that when we turn regulation on its head and move forward with purpose, we can do things a lot faster than we have. The fact that we were able to generate the vaccine in the way that we did, I think should be seen as one of the greatest scientific accomplishments of the last 100 years. And it shouldn't be seen simply as an accomplishment related to science. It's actually, it demonstrated that we can move more rapidly, and we ought to be incorporating that in the way we deal with drugs and vaccines in the future. I think there's going to be a long list of things that we learn from this experience.
Yeah. So what is one of the things that we've learned that we should make things better in a particular way? What direction are we going?
Well, I think that one of the things that was true is that social justice issues have been very much put forward in a way and have been demonstrated in irrefutable ways, and that we have to continue to concentrate and make that an underpinning of many of our policies that we have not. I think a second thing is the fact that we do need to continue to acknowledge that there are gaps in the system, not just social justice gaps, but that the way the system is financed is going to be important. I think I've already mentioned the third, and that is things we can learn about the way we can advance science. I mean, we've talked a bit about, everybody's talked a little bit about telemedicine. Vern, when we were working together in the 1990s, we were trying to get telemedicine approved. It went for 25 years, and then suddenly in 2 weeks it was, and I don't think we'll go back on that.
Yeah. It's like the old political axiom. Things look totally impossible until they're inevitable.
Yeah.
And that happens so quickly. And will we ever go back on some of these things like telemedicine? I mean, I've never had a telemedicine healthcare visit until a year and a half ago.
I don't think we'll go back. I do think that won't be smooth, though. I mean, the reason that we have trouble, the approvals were given on a temporary basis and with laws that expire, and the same forces will come back to bear. We're all going to have to push forward on this. I mean, I think a lot of this is going to be driven by the economic imperative that we have. I mean, one of the things that happened in the course of the pandemic that I think has changed healthcare in a very profound way is the fact that we now have $10 trillion more debt. $10 trillion more debt. And the U.S. health system, in my view, is shaped and will be reshaped by the impact of that $10 trillion on top of the $20 trillion we already have. We're beginning to see inflation. That's going to impact it. We're beginning to see a lot of supply chain issues, and those will continue. We're seeing shortages, those will continue. A lot of those are being driven by the sort of aftermath, if you will, of the pandemic, and now they will be driven by the ramifications of the global politics that are playing out. Now we're all just praying that this does not continue, first of all, and second of all, that it does not expand. Those who've studied history know that World War I and World War II started in circumstances like this, where events occurred and then there were different treaties tripped and different people required to step in. If that happens, that's going to have a big impact on healthcare, and we can't overlook that.
Yeah. So I just want to say we have a very limited time here, but we want to make sure that any of you that have a question have a chance to jump in. So if you would like to have a question, if you just raise your hand, someone's going to bring a mic to you, and I'm going to ask another question here, but then I'd like to turn to somebody who has a question in the audience. So just think about that and get your hand up here in a second.
Great, Vern.
What is this going to mean to all of us? I mean, change is really hard. How are we going to get there? What are the biggest obstacles? What do we have to do to make health care better and people healthier in this country?
I think if we took a bit of a poll of everyone and said what are the major issues, we could actually settle on the 3 or 4 things that drive it. To me, it's still the way the payment structure works. It is the prominence of fee-for-service billing, and the fact that we're having such a hard time moving toward anything different from that. I personally think we're in a bit of a race to see if we're able to make the changes that are required. If we're not able to change to different payment structures fast enough, I think the weight of economic debt that we have coming forward is going to continue to put downward pressure on prices for anyone who's operating under fee-for-service medicine. And that means we'll just be driving prices down artificially for the purpose of being able to meet budget demands, and that quality will suffer. So those are, I think, things we need to be focused on.
Well, just a quick follow-up on that. I mean, it's no news to anyone. The cost of healthcare in this country is double almost any other developed country. And the results that we get from our healthcare system in terms of the health of our population aren't dramatically, they aren't better, in some cases, not as good as other countries. So what can we do to bring down the cost of healthcare? I mean, that, to me, the cost of healthcare, the cost of health insurance, anything we can do in the next few years.
Well, one trend that I feel confident is going to continue is what I refer to as an asset-light delivery of health care. I think anyone in the hospital business right now has got to be thinking about this, because the way in which you drive healthcare costs down currently is to make certain that people are spending the least amount of time possible in the hospital. Now, some of that is very, very good, because it means that we're either caring for people at less costly levels of care, or it may be that we're preventing. So the premium on prevention, the premium, and this is where we get into the conversation of social determinants of health. We've talked a lot about this, but we haven't yet made it work to the point that it's diminishing the cost. But we have this downward economic pressure that is going to be resting on healthcare to try to do things less expensively. And when we do, the goal is to make certain that does not diminish quality.
Yeah. Let me see, do we have a question? It's a little hard for me to see in the lights. Is there a question? Right here, yes.
Thanks for coming again, Governor Leavitt. My question is really, I mean, thank you. Big picture, one of the conference presentations today is about price transparency. And I'm curious to know your thoughts on that and what the obstacles might be to really get us to that point. And you think that that's something that's even feasible at this point?
I've always believed that transparency would be valuable. We've had a very difficult time being able to actually make it work in the country. We have laws that require hospitals to disclose them, and candidly, they've disclosed them, but in very obscure places it's hard for consumers to find. I will also say that it's difficult. The assumption is that transparency will be used by consumers in order to negotiate healthcare prices. And it turns out, I mean, I have given this sermon quite a bit, but I've come to appreciate the fact that the surrogate for that kind of competition really takes place at the health plan. It's the amount per month that the health plan costs that ultimately becomes the surrogate for competition. So while I'm a very serious advocate for transparency, I think we have to acknowledge the fact that it's actually the insurance premium that ultimately is the means by which people compare prices, and that the complication of being able to get consumers to use that transparency to drive prices down, it's very real when it's used. It's very real, but it's just hard to get people to use the information. Many of us will remember tech companies that got into the space of being able to show price comparisons. The case that the reason that they didn't seem to take root was that consumers were just not accustomed to negotiating their own prices.
Yeah, it's a skill we're not trained at. We have a question right here. Thank you.
Good morning. And when you're talking about moving from fee-for-service for our nation, what modeling are you seeing that we can look at? I know other countries are difficult because they don't pay for their health insurance the same way we do. But even in our hospital systems here, who is making some of the moves away from fee-for-service successfully enough that the rest of the systems, or if you do see it in other countries, where did they make the move to get these kind of structures changed successfully?
So let's just acknowledge what you're implying, I think, is right, that this is an experiment. And why are we experimenting with this? I would argue it's because, I'll answer your question, but I think we're experimenting with this because we have a dilemma here. We really have a collision between two important values. One is compassion. We want to live in a society where people are cared for when they're injured or sick. It's the reason we have Medicare. It's the reason we have Medicaid. It's the reason that most legislation is driven, is this sense of compassion. On the other hand, we also want to be economic leaders. And we're in a situation right now where we are not competitive in many respects as a country. Now, I spent a fair amount of time in China over the years looking at the Chinese health system. They spend 8% of their entire economy on health care. We spend 19% on ours. They're using that 11% to go off and invest in economic leadership. And as a result of that, the Chinese economy continues to grow. We find our economy to be quite flat. And so we have this situation where healthcare is now not just healthcare, it's economic policy. And so we're saying to ourselves, we've either got to reduce the amount of healthcare we provide, or we've got to find a way to reduce the cost. Well, when we start using fee-for-service, or when we start reducing the amount we have this dilemma that whenever we reduce unit costs of healthcare, we end up with more procedures. And so we've either got to use a very strong government force to say we're going to just drive costs down artificially and let the quality chips fall where they will, or we've got to find a way in which we can balance the cost and the quality. And we are engaged in what I think is an experiment to see if we can create a uniquely American healthcare system where we utilize a regulated market to try to produce that. Now, there are health systems that are doing this successfully, but it's very slow. If I had one surprise over the last 10 years, I would say it is that we've made so little progress on being able to move away from fee-for-service because everyone can see this dilemma. What's the alternative? We're going to have the government come in and artificially begin to drive costs down and to take and to drive a quite autocratic system. Now, where's it working? Well, I live in Salt Lake City. I work with Intermountain a fair amount. They've been very successful in being able to use a value-based system. We're seeing in certain cases things like bundled pricing on procedures. That's a process. But I don't think anyone's made it work great. The problem is we've got this problem. What's the alternative? The alternative is to just spend much less money, drive the cost down artificially, and let quality escape us.
Yeah. Great question. Thank you. Who has another question here? Yes.
Hi, good morning, Governor Leavitt. Thank you for being here. I'm a physician here in Texas, in San Antonio, actually, at a nonprofit hospital system. So along these lines, when you talk about reducing costs, which we've been very focused on and very successful with, now introducing supply chain issues and cost and inflation, do you feel that's going to be a major disruptor over the next even decade around trying to make that move toward the value-based pricing and away from fee-for-service? How are we going to negotiate that?
Well, I think the introduction of inflation at high levels is a very significant entry into this discussion. This morning there's a news report. February was 8% inflation. Well, that means premiums have to go up 8%. If premiums go up 8%, that means salaries have to go up 8%. So I do think this is not good news for our effort to reform health care because of the things that we're just talking about. And frankly, there's a long history of countries, not just on their healthcare system, but on their pension systems, for example, who have tried to work their way out of this conundrum. So the answer to your question is yes, I think it's a very significant issue. And again, we've got the same choice. We can begin to use government as a means of being able to set arbitrary costs. And when that happens, when we start just reducing the amount of money we pay, we're going to see quality issues. And so this is what drives us back to the question of, can we accomplish value? Can we find a way? And what is the solution? Well, the solution is eliminating overutilization. That's one. Another is to make certain we're providing care at the most at the most efficient level. A third is going to be the use of technology. I mentioned this asset light. I don't know if we talked a little bit about telehealth. Telehealth is very much now part of a growing part of the system. And we're seeing economic markets. Wall Street is betting big on these. The Teladoc did not exist 10 years ago. Now it got a market cap in the I checked recently, but it's in the $20-30 billion range. They just bought Livongo that didn't exist 5 years ago, and they paid $18 billion for that. And it's because they're betting that you can treat people outside a hospital setting using technology to be able to drive costs down. Those are the kinds of innovations we're going to have to find. So it's eliminating unnecessary utilization, finding ways to make certain that care is done at the proper location and using technology. How do you incentivize all that? How do you get people to do transparency? Well, there's two ways you can go about it. And this is really at the heart of our political debate right now. What role do you want government to play in this? One party, the Democrats, don't trust markets. And the result of that is that they want to use the government to drive costs downward, and there are ramifications to that. The other party, the Republicans, they don't trust government. They want to use markets as a means of being able to drive those down. Well, markets are imperfect too. And so what this leads you to is to say, is there some way we can find the balance here? And I would argue the balance is, let's see if we can make a system around value work. And that's what's leading us to that. We've been doing this for a long time. I mean, if you look back at, we're 25 years into this question of, can we make a value-based system work? We're making progress, but we're not there yet. But if we don't, the solution is not a good outcome. So we just keep trying.
Another great question. Is there another question there? Another question? You know, I come from a Quaker tradition. I'm perfectly comfortable with this silence.
Howdy. So in the early 2010s, I worked in the durable medical equipment field. The government already, in our small portion of the healthcare economy, artificially drove the price down, and they did that through the competitive bid program. And that dramatically impacted the access to healthcare, especially in rural East Texas and West Texas, where they don't have, where they don't have as many providers, and the providers that were there had their revenues dramatically cut because of competitive bidding. And my understanding is that was a George Bush era policy, and it's still in effect. It's a little bit limited, but it really impacted the quality of care. So when you talk about artificially driving down pricing, how do we work on still maintaining value and access to care, especially in rural areas where they don't have 50 competitors that are like in the Houston area or Dallas, Fort Worth, those kind of areas?
Yeah, these are complicated questions. I was actually fairly heavily involved in the implementation of competitive bidding, and so the first thing you question as a policymaker is this artificial, or is this the way markets work? Basically, we just said there are certain things that are quite fungible, and so let's cause people to bid for those as opposed to just being able to set their own price, because if you're off in a place where there is no competition, then obviously you can overprice it, and there was a lot of overpricing. But your point is a good one. What if you're in a place where there is not a lot of competition, and or you don't have any providers? Look, that's the reason I think that anytime we look at a policy, it's not going to be one extreme or the other. It's going to be actually a means by which you can find a balance. And it's the reason I have continued to believe value was going to be the solution. I still think it's going to be the solution, because let me just use an example. So one of the things that I was involved in was rolling out Medicare prescription drug benefit, Part D. And what was new about that was that we concluded we want to give a new benefit to 43 million people. But rather than just have one size fits all benefit, what if we allowed private insurance companies to provide the benefit and to assemble according to an actuarial calculation of value? They could arrange the benefits according to what people wanted. That was very new, and there was a lot of it was very transparent. And actually, it turned out people really liked it because they could pick a plan that fit them. You might be interested to know that there was a government plan that was available, and people were given the plan if they didn't choose one. 6% of the entire population chose the plan that the government developed. And that meant, in my mind at least, 94% of the people chose a plan that fit them better. Well, what happened was that it actually cost less than it was projected to, because people opted for less expensive plans. There's a place where you use the government to organize a market, and then you let the market operate, and it produced a pretty good result. We've now seen that with Medicare Advantage. We're using essentially the same, and Medicare Advantage has grown and grown both in its population and in its size. And by the way, it's the one vehicle that allows for us to reward high quality at low cost. So I still believe, this is in balance, that it's not just allowing the government to cut prices arbitrarily. It's not just letting the market ultimately have its way. It's using the government to create an orderly market, to let the government organize a system instead of operating the system. And it's turning out that this is a big change and that it's taking longer than we thought, but I continue to believe it's better than the alternative if we have enough time to get there. But we're running out of time.
We have time for one question, maybe two, but here's somebody that hadn't asked one yet. Go ahead.
Yeah, and Governor Leavitt, again, thank you for being here. And I think you hit the nail on the head when you talked about the economics and the economic aspect of it. And as an actuary, call me a little bit cynical, but to me, it seems that there are so many layers of business between the funding and the individual receiving care that it continues to drive up the cost in a business economic model as opposed to a care model. And I fully agree that value-based care is the right approach with the proper incentives, as long as those mechanisms are not loopholed or abused in some sense to profiteer. And so I guess my question is, what can be done about the multiple layers of business between the funding mechanism and well, the majority of healthcare in the U.S. now, it's government funded, and the care of the individual. What can be done to address those levels of business in between the funding and the individual receiving the care?
So you present a really good example of, I think, the dilemma we face, and that is we all know that flattening that system would be more efficient and it would be a good idea to do it. So the question becomes, what is the best way to go about that? Should we use the government to somehow have a Congress or a legislature figure out how the perfect way to do that would be and to do that? Or would it be better to have have a private system that would say, we're going to be incentivized by being able to get to the lowest cost? And if we attach a 5-star quality program to it, at least people will have some version. This is the way societies, and particularly market-driven societies, work their way through problems. This transition toward value is a 40-year process. And we're about 25 years into it. And it's highly imperfect, but we are making some progress in my view. Now, why does it take 40 years? Well, it takes 40 years to go through any system this big. When you think about the internet, the movement to internet, it's been about 40 years since we've been working through this. Banking, utilities, it just takes a long time for these systems to mature. Public policy becomes important in it, so does the private sector, but over time, you have to have something that's motivating it, and we have it right now, and it's downward economic pressure, and the fact that our economic leadership is really in question right now as a country because we're up against people who are doing it more efficiently.
And it's even more difficult in the area of healthcare policy, or any policy for that matter, because so many of these are political decisions or decisions that are made in a political arena. where the time frame is 2 years or 4 years. Rarely do folks look so far in advance that they can make a decision for 10 or 20 or 40 years out in the political race.
You know, I've mentioned China, so they pay 8% of their healthcare, their economy on healthcare. No one here actually would want to be cared for, I think, in China by comparison to the U.S. system. Somehow they make that work. How do they make it work? Well, not many people lose elections in China over healthcare. And as a result, they've been able to do things in ways that would not be acceptable to us. But we're in an economic competition with them.
Yeah. I am afraid we are out of time. I know there's some other questions. Governor Leavitt has agreed to stick around through the break. If you have another question, maybe they can.
I hope we get to
talk you
interact. Thanks for
personally.
having me here. It's good to be out and traveling again. I will.
It is.
Thank
It
you.
is. Thank you very much. And I invite up now Dr. Hellerstedt. And well, Dr. Hellerstedt is joining us here. Let me just begin the introduction. John Hellerstedt has a long and distinguished career, some prestigious awards along the way, Child Advocate of the Year and so on, but a pediatrician by training, practiced for a couple decades and then found your way into the public sector. Indeed. Where you've been equally distinguished medical director for the Medicaid CHIP program, as I recall, and then for the last 6 years, great timing, by the way, as the health officer for the state of Texas, and in the course of 6 years, become a leader on the national stage as well in the public health world. So welcome. So glad to have you here today. Welcome.
Thank you, Vern. Appreciate it.
So you're a public health officer. You know, as a doctor, you improve health one patient at a time. Now, as a public health officer, you improve health 1 million people at a time. Let's just start with what is the elephant in the room, which is the pandemic. You've found a way to become one of the country's experts on COVID and pandemics. Actually co-authored an article in a book, which I understand. So the name of the article was Resilience is Key, Lessons from Past Public Health Disasters. And you actually wrote that before COVID.
That's right.
Yeah. Tell us about
That's
that.
correct. Well, it's in a book from Texas A&M University Press called Preparing for Pandemics in the Modern World. It was a symposium that was held in 2018. I got asked to write an introductory chapter, which we finished in 2019, but they didn't get around to publishing it until 2020. So it looks like it was all, post facto wisdom, whatever wisdom is there. But we really went through past public health disasters, not just pandemics, but the 1918 pandemic, the 2009 H1N1 pandemic, the situation with Ebola in Dallas back in 2014, Zika, and then Hurricane Harvey, and kind of compared and contrasted those things. And the big takeaway lesson from that was, unlike something like Hurricane Harvey, where it's flooding in Houston, but it's sunny in San Angelo, in a pandemic, which we've all lived through now, everybody everywhere is facing the same challenge. And so, although people could come to the aid of Houston from all over the country, with the pandemic, we've really had to make sure that we were taking care of who were our immediate responsibility. And so the ability to really kind of lend resources and things to other people was much more constrained. So we had to create new capabilities that didn't exist before, especially around things like data, and also to scale up capabilities that we had. And so, the thing it is, we wonder, will there be another pandemic? There's a possibility there won't, because science will develop so robustly that the biology of all of this will be transparent to human technology. And when something begins to emerge, we'll immediately have effective countermeasures for it. So that probably will happen someday, but when? And so is there a pandemic that's brewing somewhere in the world right now that could emerge? And the ironic thing to me, when in looking at writing that chapter, was that here we are in 2020 when this pandemic really took hold. We found ourselves in the same situation basically that the world found itself and America found itself in the influenza pandemic of 1918. We had no vaccines and we had no effective medicines, no effective countermeasures. So those profound basic things were the same 102 years later, but absolutely everything else about society had changed. And I think we're seeing that change kind of playing out. So for this pandemic and for any future pandemic, it's not just about science, it's really about society. And of course, the activities of science are a subset of the activities of society. But if we look back at the experience that we have in this pandemic, I want to make sure that we all look back with 20/20 hindsight and not with blindsight. In other words, that we look back at the journey that we've had, we understand why decisions were made, why things took place the way they did, and we're prepared to deal with, again, if there's a new pandemic, it'll come about because that organism has evaded all our defenses. And so we'll be, in some profound ways, back in the same place that we were. And we need to, again, understand that it's about preparing society for that situation where you're dealing with something that's dangerous, with something that's ambiguous, where you don't have all the answers, where you're going to need to develop new capabilities and expand capacities that you didn't have. I think too, I worry that that people are saying things and writing things in a way about this pandemic that make science and public health look bad. And they don't understand the fundamental paradox of prevention. So if you see a risk coming and you take steps to avoid that risk, that's a success, right? That's prevention. But for a lot of people, they look back at where we are today in the pandemic, where all of the indicators that we have are very favorable. Not to say there couldn't be a change. If that change takes place, it'll take place because of the biology of the virus itself. You'll have a variant that evades the immunity from previous infection or from vaccination. And so, what we need to look back at what we did and understand how successful it was. It was very painful, but I say we're successful because we're here. We're still able to have our economy function, which is not just about making money. As we know, it's all about having vital goods and services available to keep the society moving. And so we have done that. And I will tell you, early on, if we hadn't taken the countermeasures that we did, which were in fact effective, we really put at risk the idea that we would not be able to carry forward with society in the same way that we have been able to. The big risk early on is if you didn't have any countermeasures, you didn't take any precautions, that so many people would get sick all at the same time that especially the inpatient healthcare capacity would be overwhelmed. You would not be able to take care of women who needed to deliver babies and 5-year-olds who needed their appendix out and families who'd been in car crashes and people who had strokes and heart attacks and things like that. If in this society we had gotten to the point where there was not room at the inn, so to speak, for people who needed that kind of life-saving care, I think we would have gone from disaster to catastrophe because people would have lost confidence in the ability of the system to take care of themselves. So we have managed to get where we are, I believe, through providence and also through good policy. But one of the things about the policy is, and I've said this to my governor, I've said it to as many people who will listen, that science can advise, but science by itself cannot devise good public policy. Because as the governor was alluding to earlier, public policy is all about making compromises. And in the pandemic, you had two good things. There are two forces that are in moderation are good, but if taken to the extreme, could again lead to a catastrophe. What am I talking about? Well, one good thing is to decrease the spread of the virus in your community. It's a respiratory virus. What's the most effective thing against a respiratory virus? Physical space, just staying away from each other. So if you wanted to take that to the extreme, you would have had a shelter in place. You would have had a lockdown. And clearly that wouldn't last very long without producing its own catastrophe. So you needed to be able to get people to interact, to go to work and do things. And that's where the other non-pharmaceutical interventions came in. Some physical distancing, masking, sanitation, hygiene, and those sorts of things. And those worked. Don't forget, early on, we had a big surge in COVID-19 back in 2020 before we had the vaccine. And it went up and it came down. And it came down, if you look, and the timing is very close to when the timing of people got serious about some of those non-pharmaceutical interventions. And people will say, well, there's no proof that masks work. Well, yes, there is, because essentially the flu seasons in that period of time were de minimis. You almost didn't have a flu season in the Northern Hemisphere during that period of time. And the only possible explanation is, again, in total, those non-pharmaceutical interventions that people were observing. So again, my biggest theme, I want people, all of us, to be able to look back at the pandemic, to see it as a success of our society, and to understand that going forward, if we have to face something like this again, whether it's a pandemic or some other serious public health crisis, that the key to it is crisis communication. And I think, unfortunately, that was not handled well at the beginning of this pandemic. And in crisis communication, if you want to be the authority, i.e. as government, you need to be first, you need to be truthful, and you need to give people something to do to protect themselves. And those clear messages, in my opinion, were lacking at the outset. And unfortunately, then the situation has devolved kind of to the point where we are now, where there's so many dissonant voices out there in terms of, again, science, public health, and how the preventive measures that we undertook really did work.
Yeah, that was a fantastic. It was more than a response. It was you actually covered the waterfront, and they're just superbly well. So, but just looking back, I'm just thinking the last kind of major pandemic. There were others, of course, but the Spanish flu 100 years ago killed millions of people around the world. That was a disease that focused. The death rate among young people was really high in that, and old folks didn't seem to be affected quite as much. And the reverse was the case. Maybe you can have some thoughts about that, about how that happened and how things have changed, lessons we might have learned from 1918.
That's a great question, Vern. I can't say that I'm an expert about that, but a couple of things seem to me to be very different. Yeah. So if you look at photographs of 1918, what do you see? You see in particular that it hit the military very hard, right. And you see these military hospitals where the cots are about 1.5 feet from each other. They really aren't wearing masks. It's the worst congregate setting that you could possibly have for the spread of a respiratory virus. So I have to think that had a contributing factor. I think just generally the mobility in society may have had an effect on that it was the younger people who were going to work and all that sort of thing, and older people who may have not needed to be as mobile or have the advantage of being as mobile as people are today. So that's just some thoughts. I don't think that it was necessarily a difference in the biology of the virus itself. We call these novel viruses because no human population has pre-existing immunity to it. But they're still viruses. And I'm kind of getting back to our current COVID-19 crisis. And, we know how to protect ourselves against viruses. Even, we had to develop the vaccines. They're a godsend. My other message is booster, 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 booster. It's the thing that we need to have.
Should I get a fourth one?
Yes, and a booster. That is going to be the thing that guarantees, as much as we can, that we have really put COVID behind us.
Yeah, I'm intrigued. You actually offered the prospect that maybe that there would not be another pandemic like this in the future, because science may have epidemics have been with us for all of time. They're described biblically, and through history. The Black Plague and Black Death and bubonic plague and so on. Just historically over the centuries, they have been there. Is there really a prospect that we may have reached a point where we wouldn't expect to see another?
I think so, but like a lot of things, like for instance, Governor Leavitt was talking about the evolution of the healthcare industry and healthcare financing. When I first started in practice, we were absolutely convinced that we were, the group that I was in was the model for preventative healthcare and all that sort of thing. And as my boss used to now says, everybody knows what's going to happen, just nobody knows when. And so I think that comes, that's true of that sort of, again, where all biological systems become transparent to human technology. What do I mean by that? Well, very shortly after the SARS-CoV-2 virus was identified, which is the cause of COVID-19, its entire genomic sequence, the entire key to its genes was published. Someday, I think we will have the ability to take that genetic sequence and then immediately understand what the countermeasures are. You say it codes for this, it makes this entity, this virus, and here are the things that are going to be effective against that particular organism. But when?
Yeah, but when? So we've got time for a couple questions. We're going to end right on time at 9:45, so we have time for a little break before going to the breakout sessions. So get your questions ready here, but while people are thinking about their questions and raising their hands and a microphone coming toward them, so what's next? What is next that we're going to be doing as this, hopefully, COVID pandemic phases down?
Well, I'm very hopeful that we can, and we are doing our very best at the Texas Department of State Health Services. And by the way, I was remiss. I didn't thank everybody in the room. I didn't thank everybody in public health, again, for contributing to the success that we've had. But going forward, we've been given an enormous opportunity to fund public health infrastructure, to flesh out and have more staff. And of course, in Texas, we're a home rule state, so we have many city and county health departments that are independent of the state Department of State Health Services. They're getting funding, we're getting funding. So personnel, more trained personnel, better data systems, more modernized data systems. I think all those things will help. And I hope that those are capabilities that we will retain in the future.
Excellent, excellent. Who has a question? Over here, yes.
Hello, thank you. I guess my question is related to more of human behavior, because a lot of the pandemic has continued due to human behavior. And we recognize that we have people who come into our clinics and hospitals all the time who are not vaccinated, who don't believe in the science of vaccines. And so if we do reach the opportunity to have the medical interventions to combat another pandemic, how will we help our community be online or be on board with the science behind that?
I think that's a great question, and you're absolutely right. It goes back to saying it's not about science, it's about society. And so how do we elevate the medical literacy, if you will? And the amazing thing to me, having been in practice, medical literacy is not related to socioeconomic status or anything else. There are plenty of doctors, I think, who need to catch up a little bit on some medical literacy, by the way. And so I think the key in the future really will be at the outset to have that appropriate crisis communication with society and say, here's what the threat is, here's what to expect, and here's what you can do to protect yourself. Lacking that, you play catch up. But I think going into the future, I hope again that we look back at what happened and see the value that would have been there had we had that appropriate conversation at the beginning.
Other question?
Hi, thank you for being with us this morning. So our state's constitution was written in the mid-1800s, where science was very different, and people had different things to consider at the time. But it means we're locked into 140-day sessions. And it strikes me that the winter freeze that was unprecedented hit when we should have been spending a lot of time focusing on things like how we respond to the pandemic. And so then when you have to shift your attention to something like an energy crisis and deal with that, it really hampers your ability to deal with scientific issues. And that's just sort of a procedural, political thing that's baked into our government. So I'm curious if there are things in the administrative side of the way our government works that you found were inefficient and kind of hampered your ability to combat the coronavirus.
This answer may shock you, but the answer basically is no. I don't think that was a hamper. Among other things, one of the things that I think worked really well for Texas, and that I think is in a contrast to something that we see at the national level, when the governor and I were early on in news conferences together, I like to think, anyway, that it was very clear that I was advising, he was making decisions, he was making policy. And so he's made policy many times through calling special sessions as well as his executive orders. So when we have this kind of emergency, when we have this kind of disaster, there are ways to make things happen a little bit faster. I will tell you what a really great example of the communication between science and political leadership is, and that is our expert vaccine allocation panel, which was a 17-member group of people. It had previous public health folks, experts on the science piece, but among other things, we also had 4 senior leaders from the Texas legislature, 2 from the House and 2 from the Senate. That was a really great experience because they could see firsthand that there was a lot of science involved, that people in public health were very serious about it in terms of constructing the right policy, because early on what it was all about was there was a very short supply of vaccines initially and a very high demand. So how is it that you create public policy that lays out the priorities for the populations that you want to immunize first with this very precious resource to ultimately impact the greatest benefit of the common good for all? And having those senior political leaders participate in that, I can assure you, they came away with a new appreciation again of what it takes to create good public policy with science as its basis.
Yeah. Where's the next question? Yes.
You mentioned better data systems, and I was wondering if you could expand on your vision for that, and in particular, how local and regional data sharing systems fit into that vision.
Yeah, I mean, basically, among other things, so for example, here's COVID-19. It's a reportable disease. For the first time ever, with a reportable disease, we wanted not only the positive results, but the negative results as well. So suddenly now you're testing in the millions, and you needed to have a data system that was robust enough to do that. We needed to interface with national systems that were also created de novo in order to manage things like the therapeutics, in order to manage things like the PPE and things like that were in scarce supply at the beginning. So being able to create those interactive systems was the main thing. And then again, here in Texas, because of our home rule, we have many excellent city and county health departments, and they have their own data systems, and we need to be able to speak with them fluently. And so it's not that it didn't allow us to speak, but it didn't necessarily allow us to speak fluently. And so I think going forward, having that ease of data exchange is really helpful.
Okay, we have time for 2 questions there, and then you'll finish up right here.
You mentioned, Dr. Hellerstedt, about the additional funding that the state is investing in public health and local public health districts. Are you optimistic that as we begin to shift the focus around, particularly with COVID and other potential threats to our public health system, how do we begin to work on funding and implementing programs to, more preventative? So we should be investing in research around lessons learned with genetics, like you were saying, any genetic predisposition or any comorbidities that could be addressed at a public health level. Are you optimistic that that is going to be a shared focus amongst Texas local districts?
I think, if I understand your question, part of it is, is the funding going to make public health in Texas better and more robust? Yes, there's no doubt about it. We realize this is an amazing opportunity. We're being very, very diligent about saying this is a once-in-a-lifetime opportunity in a certain sense, and so how do we maximize the benefit that we get? As to certain other things like chronic disease and that sort of thing, there again, I would really say that goes back not just to science, but to society. And if we think of the changes that have taken place in society that have lent themselves to the emergence of chronic diseases that weren't problems before, I think, to me, that is a society-wide solution that is not just going to be the healthcare system, not just doctors and nurses, not just public health, but really all of society understanding that if we're serious about making those things better, it requires a society-level change.
Okay, quickly, we're almost out of time.
Okay, the most lasting change. We've all gone through a major shift globally. Here at home, we know that there's kind of been a tale of 2 curves before the pandemic, with the pandemic, data, information use globally, locally. But we also went through where if this was a more bad acting virus, like that caused encephalitis or some of the others that could shake loose out there, what are those points of light that we're all going to shift that are going to stay with us, both to the positive, and where are the threats from what shifted that we did locally and globally that may last, that we need to address after lessons learned come in, that we're going to shift and focus on those positive changes that came to us as health, but also there were some big major fractures that opened up locally and globally too. So what are the 2 main takeaways for these lasting changes from your point of view, and how we all act and capitalize and move together on those?
Great question, and I hope that summarizes the point I'm trying to make, which is that the science and the public health are sound, they are reliable. What is important is society and policy and communication and people's understanding. What really this is all about is we're trying to persuade, because we live in a free society, we're trying to persuade people to act in a certain way that talked earlier about behavior. People will only behave in a way that they trust. And so, again, the thing that I want us to take away from this is that when we face any kind of crisis, a public health crisis or a pandemic, it's going to be about having communication that is truthful, it's prompt, it's trustworthy, and it gives people something to do to protect themselves. And that will be, we will always have something to do to protect ourselves. It's the kind of the point I was trying to make about it's a novel virus, but it's still a virus. We know how to take certain steps to protect ourselves against pretty much every kind of infectious disease, contagious disease. But we need to have people trust that the measures we're asking them to take to protect themselves really work.
It's a great way to finish up. Thank you so very, very much. Dr. Hellerstadt, this was a terrific session, and best of luck to Texas. You all have gotten such high marks around the country for how you've handled all of this. Just tell me, what are you most proud of?
I am proud of the fact that under this stress, we have had no deserters and no whiners. And I can say that about all of public health in Texas, which, considering the incredible stress and sacrifice that people had to make, that is praiseworthy. Awesome.
Thank you.